the previous discussion about the laparoscopic versus open ventral hernia repair, it seems to be a very interesting discussion. And I have to admit, as a fan of laparoscopic surgery, that one of the procedures that I was a bit disappointed when I started to practice laparoscopic surgery is ventral hernia repair with laparoscopy. Because many patients were complaining about pain. Doctor, it's very painful, not only acute pain, but... So they were complaining about pain, one of the painful issues in laparoscopic ventral hernia repair. Acute pain and chronic pain, most probably due to transfacial sutures. I want to ask the panel, was at least the people who are practicing laparoscopic ventral hernia repair, do you agree? Tim?
I agree. I agree completely. The laparoscopic approach is by far more pain. In average, on a vast scale, the pain is twice as intense as with open surgery, and the time to no pain is also double. It's almost 1 month for patients to have no pain. And for that reason, a lot of surgeons will reduce the amount of sutures and tacklers, perform bad surgery, have recurrences. So whether the decision is whether you do it or not, but if you do it laparoscopically, then do it well or don't do it. And if you do it well, good pain and management should be done. And this is one of the issues that I have seen in all of my trips now to Israel, is one of the things that is underestimated. All my patients get standard in epidural for that, all of them. Whereas I can see here, this is absolutely not the case. I will have to discuss with anesthesia to have even a patient-controlled pain management. So this is something that is well established in my unit, and it would not be the first time that I would do a re-laparoscopy for an acute abdomen, which is just solely due to the pain. So pain management is absolutely important, or you should abandon the laparoscopic approach. But you should not compromise in less fixation, and that is what we instinctively do. We under-tag the meshes, we don't put enough sutures, and in the end you will have poor results.
Pain management is probably one of the most important aspects that stand in favor of laparoscopic repairs in any field of general surgery, and when this doesn't exist. So the rationale for laparoscopic repair drops a lot. But I would like to, you want to discuss only pain now?
No. There are many questions.
I will say up front that my personal view on this discussion between lap versus open, POVH, is, I'll tell you this. When I insisted on naming this new forum, this new society of forum that we have, not only hernia forum, but surgery of the abdominal wall forum, this was based on the understanding that the physiology of the abdominal wall is extremely important. And when we repair a hernia, we actually do not repair a hernia. We repair the abdominal wall and need to reconstruct and bring back the physiology of the abdominal wall. Putting a cover, a synthetic dead cover from the inside is not restoring the abdominal wall, especially not the physiology of the abdominal wall. It has drawbacks in terms of cosmesis, which is very important. It has drawbacks in terms of functional aspects of the abdominal wall, and it presents limitation in physical activity, especially for the young age group. So, in my opinion, this is the main reason why open repair has more chances of restoring the function, the physiology of the abdominal wall.
Is it size related?
About size, this size is always a good question. I agree, totally agree with Igal that what is probably, I don't know if 10 centimeters diameter is the number, but something around 10 centimeters, there is no question. In my opinion, it need to be repaired by an open approach. And as for the smaller, the extremely small lesions, I don't see any justification for the laparoscopic repair. So I don't know, in between, I end up repairing most of them in an open fashion.
About the physiology of the abdominal wall, I was in one conference that it was discussed. First of all, if we look at the studies, there is no difference between lap and open approach in the physiology, or if we talk about the activity of the patient. So how do we assess the physiology of the abdominal wall? There is no way to do it, whether the patient should do sit-ups. So in this conference, everybody showed the way he is doing laparoscopic or open repair, and they showed films of patients doing sit-ups 60 days after the operations, and those that did the laparoscopic repair did sit-ups and did the open repair. And another guy coming from New York wanted to show his patients after open repair, retromuscular, but most of the patients were older than 70s. And he was not allowed by the physiotherapist to do sit-ups because it may cause lumbar function in these elderly patients. So there is no way to assess the physiology. We don't know the way. One guy is working on some kind of a machine to estimate it, but there is no real way to analyze it.
I would like to have two questions. One, you never mentioned the point of time. You see, these extreme cases that you showed in the slides, most of them are hernia are produced in years. Usually it starts with a small one, and then the clever doctor says, hey, it's nothing. You don't have incarceration, it just grows. So it grows and it grows and it grows, and then it becomes a challenge, and then it becomes a paper. I think that we surgeons, I don't know, I want to know what you think, that we surgeons have to take this time in consideration and not just say to somebody, you have a small incision hernia, I don't care. Don't let it grow. Maybe it's an indication to operate much earlier than we do. Second question is a kind of attitude. In my age, I can philosophize a little bit. Abdominal wall, where does it start, where does it end? But it starts when there is no bone, I understand. And then you go to an inguinal hernia and say, well, you have a 4 centimeter gap, so bridge it with a mesh, whatever you like, this kind or this kind, everything is okay. You go 4 centimeters medial. You go to the midline, low midline, suddenly it's a new thing. A centimeter here is not a centimeter there. You have other rules, you have to do it different way. I think that we are a little bit thrown to the corner of kind of medicine, and we have to, at least for ourselves, to understand the same rules for hernias. Not just incisional hernia, different rules. Diaphragmatic hernia, different. Morgani hernia, different. Everything is different. I don't think we have to make the world so interested for us. I think we have to standardize it. I don't think that we are now ready to give the answer whether to do a laparoscopic or an open surgery. But we should at least treat ourselves to be sincere and to say, hernia should be treated like this, and this is the principle. This is tension-free. 4 centimeters? No, 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 no. different approach, 4 centimeters, maybe 5. Then you have hernias like this and hernias like this. You don't mention lumbar hernias, things like this. You don't mention other kind. Most of the hernias today, I think, nobody did a statistic, is a laparoscopic hernia, small trocar hernia. I think these are the most, it's called incisional hernia by anything you judge. So I would like to have you guys mention or say something about these 2 points.
You mentioned that you would like to operate those patients earlier in order to prevent such big hernias. I would like to comment on 2 things. First, over hundreds of cases of huge complex hernias, I think, I will publish that, but I think over 50%, even more, started as an umbilical simple hernia. Umbilical simple hernia, which perhaps, I don't know if you or anybody in the audience would say, oh, go ahead, do it. Any way you do it is okay.
That were treated openly in the old days, with no mesh.
That were treated badly in the old age. And this is what I would like to comment, that not only to operate them earlier, but operate them with skill, operate them with will, and operate it when you really give it the right place and the proper time for that. And not send somebody who doesn't know how to do it to operate it because, well, what can happen? What can happen you see here? This is what can happen.
Does it seem that we have a consensus? I mean, small to medium-sized hernias, ventral hernias are suitable to laparoscopic repair, large, complex hernias are not. Tim?
Of course, and obviously there is a lot of hernias we did not address that are maybe even much more complex. I'm thinking of the parastoma hernias. Nobody likes to treat them. I've got quite a big series now, and it's something that has such a variety of approaches and complications and so on. So it's very complex, let alone to talk about lumbar hernias or perineal hernias or suprapubic or subxiphoidal ones or diaphragmatic ones, or there's a vast majority. In the end, the first thing we lack before we can talk about anything in life is a good anatomical classification system and a good registry. And very few countries can produce that. Denmark has now a good registry system implemented, and the data that we are getting from teams led by example by Jacob Rosenberg, it is unbelievable. For the first time, we see that Liechtenstein, according to the Danish people, but I'm sure they don't know how to operate, but has 7% of recurrences in Denmark. So it's a bad country to go to. It will be everywhere the same, I believe. The thing is that we don't register. We have a European registry system available already. We have, it's called EURA-HS registry system. It takes me more to register the patient than to operate the patient in a lapinguinal hernia repair. So it is just too complex and we are not yet there. So I think first we need to classify properly, and then we need to register properly before we can actually come to data. If there's anything in hernia surgery, what we lack is data and proper data. And a lot of things we do is experience-based. And of course you can listen to people that have a lot of experience. I love to listen to Reinhard Bittner, 16,000 laparoscopic inguinal hernia repairs in this unit, and there's a certain evidence in that, but quality-wise there's a lot of differences in evidence, and the big things we will all agree to. We need mesh, yes, we need mesh. It's better to put the mesh behind the defect, yes, we will all agree. But once that is said, anything except for that, we will disagree and we will have other opinions. So very much through statement, I agree.
I wanted to comment about Professor Haroz's comment. I believe it was a very important comment, mainly because it provokes thinking. And with regard to centimeters, I'm not sure that the difference of 2 or 3 centimeters is not important. It depends on which side you stand.
Depends on the mirror.
Yes, so about centimeters I don't know, but really without joking about it, the physiology of the inguinal region is probably different than the physiology of the linea alba.
Structures involved.
Yes, different structures, different musculature, different forces, different organs. Actually, it's completely different. It's not just a matter of 2 centimeters to the side or to the middle. I really think that we may have different attitudes or different strategies toward those different areas of the abdominal wall. This is one thing. Think about diastasis recti, for instance. Is it a problem? Is it something that interferes with normal life of people, with physical activity, with cosmesis, etc.? I believe it is.
Cosmetic.
No, for physical activity. Try to imagine young people, age 20, 30, 40, that want to be active physically. And actually, when you put in the linea alba a mesh which covers a defect, and it doesn't reconstruct the linea alba, you leave him with diastasis recti, with kind of diastasis recti. So it is again my belief that restoring the physiology, the normal physiology, as good as you can, is very important. And now you come down to the question of size. I really don't know the answer. We don't know the answer. The huge hernias, it's probably, there is a consensus probably. The 1 centimeter hernias, I don't see any reason to treat them laparoscopically. Maybe you do, somebody does. And the medium size, I really don't know.
What do you think? Do you agree to this kind of consensus?
As the audience see who is going 2 centimeters umbilical hernia, my open technique here, I think 80% of the people for the last 15 years are doing it laparoscopically.
I want to comment
And that's all.
So what?
What does it mean?
That you are alone in your opinion.
Let's
Let's ask people. Umbilical hernia, 2 centimeters.
Umbilical hernia. Guys, 2 centimeter umbilical hernia. Who is doing it laparoscopically?
2 centimeters?
2 centimeters.
Open.
Even me.
Did you come?
Most of the audience.
So,
No.
so the role is not. So the role is not alone.
But what about 2 centimeters in morbidly obese? That's another problem. It's not another problem, it's the same problem.
יש פה עדינות לשאלה שלך. כולם פה עושים אופן, אבל לא כולם עושים פה לפרוסקופי. לא קשור הרלד או לא הרלד. אז אי אפשר להגיד מי עושה פה אופן ו...
פה זה קטע של חילה, מי לא עושה כל הפוסט?
יש.
No, really, we are. This is not the forum, but we are trying to reach kind of consensus. Because we have heard all these experts, and Tim also told us that perhaps large and complex ventral hernias are not suitable to laparoscopic repair. Dr. Yampolsky is pro open repair, even with medium and up, medium size and up. Am I right?
Just I want to
Okay.
let him
So it seems that, according to these experts, laparoscopic repair is suitable to small and medium-sized, not too large ventral hernias, because of many reasons that they were discussing. Okay?
אפשר גם שאלות מהקהל?
כן, אפשר, בטח.
רגע, אבל הוא מעמד
אז טים רוצה לענות, אחר כך טים, we are waiting for your answer.
Answer to what?
All together.
What's
your limit?
When 7 years ago I presented the first laparoscopic umbilical hernia repair on a congress, so this is before anybody was doing it, I was yawned away by people. People were woo-hoo me, the industry guy and so on. And that was 7 years ago. I showed the first laparoscopic umbilical hernia repair. 1 year later, I had a lot of people doing the same thing. 5 years later, it's almost half-half if you look at the group. And maybe in 5 years from now, we will say that all these meshes intra-abdominally carry too much risk. I can only say that when I talk to my seniors and older surgeons, and I love to talk with them because they have one thing I don't have, it's gray hair and expertise and experience. Very often we go back to the old-fashioned principles. That's one. And the second thing I want to remark is that basically there is more consensus in life and in what our practice we do. There's more consensus than we would think there is. What we lack in most of these things is data. That is going back again to the same thing, proper classification, proper registry, and then bring our data and show that indeed, for example, a simple Liechtenstein has more recurrences than we would think. Everybody thinks the same numbers of 1% and so on, but the reality shows totally different things. I could not believe that our primary suture for small umbilical hernias would have high recurrences. So I did a recall on my patients, 5-year follow-up, recall on my patients with primary suture done by my chief of umbilical hernias. For the ones that would come, we had 43% of recurrences. And this is the ones that would come. So the ones that did not come have maybe even bigger. So there's all a question about gathering the adequate proper data. But in behavior, I would say that educated, trained people, surgeons that go to congresses that are sitting here, there is much more of a consensus in our clinical behavior than you would think. Whether that is evidence-based, that's something totally different. There we differ a lot.
What about the obese patients? Is it a contraindication to perform repair of ventral hernia? I mean, you insist to reduce the patient to reduce his weight before repair of his weight before repair. Another question, please. The same patient, obese patient that is going to perform a bariatric surgery with a ventral hernia, do you do it by one step or 2 steps? First, where the step 1 is the bariatric surgery, and then step 2.
Yes. Luckily, I'm not. Regarding your first question, what was it again? Obese patients, weight loss before surgery or not. Of course, it depends what we're talking about. A 130-kilogram patient, most of us will be able to treat. In the beginning, obesity is seen as a contraindication because one lacks the experience to treat these patients. Once you have that experience, it's sometimes more easy and more quick to do it laparoscopically than open. Of course, once you go to 180 kilograms, I mean, not me is going to treat it, and not Igal is going to treat it. I mean, both of us will say you have to lose weight and maybe put an intragastric balloon and then do a gastric bypass, and then we will reconstruct. I was once flown into Oman to treat the sister of the wife of King Sultan Qaboos, and a very serious hernia. And the only thing they lacked to put in the file was her BMI. And when I got to see her, the BMI was 57, 57. I just took my plane back and said, bye-bye, hasta la vista. I mean, and everybody was disappointed. And I wrote a program and said she needs to go on a diet, have an intragastric balloon, lose weight. And then once she's lost her weight, I will come back and I'll do the reconstruction plus the abdominoplasty for free.
And that's what happened with that patient. So obesity needs to be tailored to the patient, to the techniques. And in the beginning of experience, one should be more careful. Once you have that experience, it is possible. Take in mind, though, that a lot of these patients have a lot of comorbidities. Pulmonary, diabetes, metabolic disorders. So one must be careful with that. As far as combining surgery, I hate combinations. I don't like it. I know it's very fancy to do and cholecystectomy and umbilical and this and that. I hate it. The only times I will do it is when I'm convinced that it should be done together. Kind of like to do a pelvic floor reconstruction. I do a lot of pelvic floor descensos and putting a rectopromontoropexis with a mesh. Then you need to combine it with gynecological procedures because they need to take care of the middle and the anterior compartment of the pelvic floor. And there's one shot to do it properly. That needs to be done always together. But except for these anatomical considerations, I hate combinations. And I refuse it in my unit. Just one remark on that. Obese patients, that's a problem. Why a problem? Because it's very easy to tell the patient, listen, lose 30 kilograms and come back to me. It's like telling him, go ahead and be a space pilot or whatever. He's not going to lose 30 kilograms. And it's telling him, I don't want to operate you. But I think I shouldn't tell him, we shouldn't tell him that he's not going to be operated until he loses weight. We should explain him what will happen if he will be operated in this situation, what are the risks, and what is going to happen if he's going to lose 30 kilograms, and what are the benefits of that. And then to offer him operation, even if he didn't lose weight, because to leave him in a colossal hernias like this, I'm not talking about those 180 kilograms, but all the rest should be operated, even though they did not lose weight.
But why offer him a diet and not a bariatric surgery?
If he's ready for a bariatric surgery,
This is the indication.
if you think that this is the indication, I'm not speaking about bariatric surgery at the moment. I'm speaking about the situation that you refuse to operate the patient because he's too fat. And we shouldn't do it.
I think that we should refuse. It's not refuse. We should treat the patient first for the morbidly obese and then treat the hernia. Otherwise, we can do the operation. The one who is going to suffer is the patient. And we must understand that if the patient has complication because he did not do what he should have done and lose weight, then we are the one that are responsible for it. This we must keep in mind, okay?
I think last question because we have to move on.
Going back to the 2-centimeter umbilical hernia, we said the principles are important. So primary suture is not good. I don't see how you can put a good mesh on a 2-centimeter umbilical hernia with good coverage when you do it open. I can't see technically. Unless you do it onlay, which maybe you do.
No.
Otherwise you need to make the space much bigger because you need to have 5 centimeters overlap on each side.
For 2 centimeters you need round ventral legs, 4.3 centimeters. Very easy to put it. Very, very easy.
There are different techniques.
Okay, but for that, for you to sit in front of the patient, you need to have informed consent. You need to have the information. You need to know what to tell him. What are the recurrence rates for this approach and for this approach, and this is that actually we're lacking.
Can I comment? It's very important what I'm going to tell.
Very shortly, please.
First of all, I want to tell some cases this year. As you know, I also work in Carmel. In Carmel, we had a case at the beginning of this year, I mean at the year 1913, a patient who had an umbilical hernia repaired laparoscopically. She came with peritonitis, was ended with ileostomy, and all over, and of course a trial and everything. But that's first one. So we have to know that these operations are also connected with severe morbidity and mortality. Now I want to tell you something happened these months. A patient came to me a year ago with umbilical hernia. So I said, oh, no problem, I'll fix it for you. Very small operation, very simple operation. No, I heard there is something extraordinary. They put some holes, they do it laparoscopically. I said, don't do it. No, he didn't hear to me. So he went to a very good specialist. And he said, oh, you go to Professor Engel, he's driving a Susita. I have a Mercedes. I have a Mercedes. Okay, he did with his Mercedes this operation. The patient had for 9 years severe pain. And at the end of these nine months, he suddenly saw that the hernia came out. He did an ultrasound, and there was a recurrence. Now he came to me. Okay, in a very small operation, I fixed him. The sac was inside, the tuckers was outside, and in 25 minutes, everything is finished. So, a month later, he sent me a mail. He's a very, very intelligent person. He compared the two operations. He is a golf player. He came back, he came a medal, and I don't want to write. I have it's written. He said, every patient want to do this operation have to hear to me. I'm not a doctor. I had the same two operations.
The Susita is better.
Yeah.
Of course. The open technique is much better.
חבר'ה, להצטייר זה קדימה, בוא.
It's shocking.
לא, כי אנחנו...
I have 3 remarks. One about pain of laparoscopic ventral hernia repair. I had the impression that when you put one layer of tacks, it's more painful after the operation. If you are putting 2 layers of tacks, it's less painful. I'm not sure that I'm right, but this is my impression. The other thing is adhesions to the mesh. Sometimes you go back for another reason. For a patient, you did ventral hernia repair with via laparoscopy, and sometimes with the same mesh you find adhesions, and sometimes not. And I was thinking that these things that you are doing, Dr. Torrens, the removal of the fat, or maybe injury of the peritoneum, the parietal peritoneum, might cause more adhesion intra-abdominally. I'm not sure about this, but this is my notion. The third thing I wanted to say relates to what Dr. Karim said about that 70% of the patients don't need the component separation. And this corresponds with the fact that you close the gap laparoscopically, and you are not doing any component separation. So I think it corresponds with the fact 70% doesn't need this huge operation.
About adhesions, some patients undergo laparotomy without any mesh and they have severe adhesions, and the others don't. We don't know exactly what causes the adhesions. We do know that some kind of mesh cause different kinds of adhesions at different percentages. Some kind of mesh causes very sticky adhesions that you cannot see any filaments and just get incorporated into the mesh.
That's the Prolin mesh.
It's not only the Prolin, it's also meshes that are manufactured for...
Gore-Tex is not doing it.
Right, Gore-Tex is not doing it. Gore-Tex is not doing anything. Gore-Tex is not doing any incorporation, is not doing anything with the tissues. It just got encapsulated. It's not getting incorporated. And the other thing, also we see some kind of meshes that are presumably manufactured for laparoscopic approach, and we see much more adhesions with it. And also we see it in studies afterwards. After we saw these adhesions, a study was published in England about this kind of mesh. I don't want to mention the name of this mesh. And another thing about the pain, we don't know if it is the tacks or the transfascial sutures or just the mesh. We know that pain is part of inflammation. We know that the patient develops inflammation, and this inflammation is very important for the next steps of healing that will incorporate the mesh. We know that if we examine the patient after laparoscopic repair for the first 48, 72 hours, the patients show us signs of peritonitis. We cannot touch the area that is covered without causing pain to the patient, without having defense in this area. And if we examine the abdomen that is outside the area of the mesh, it's completely soft. So something is happening between the mesh, with the tuckers, without the tuckers, with the sutures, without the sutures, that causes inflammation and causes pain. Some try to do it with covering the mesh with omega-3 and try to have different kind of inflammation. Some say that they even had less pain with this kind of approach. And we must always think about what we can do, like can we use other meshes, can we have local anesthetics, can we have some kind of coverings that will reduce the pain in these patients, long-acting, local anesthetics and so on. So there is also
I will continue, just 1 second. I will continue what you just said, that something has to be done to prevent this inflammation. Something has to be done to protect the intestine from the mesh. Something has to be done in order to prevent those adhesions, sometimes more and sometimes, as you mentioned, less. This is, you know what it is, something that has to be done.
Momentum.
No. You don't always have the momentum, unfortunately, in these cases. But what you have to do is put another layer of abdominal wall between the mesh and the intestine. If you do it, if you persist on doing it, if you will be convinced that you have to do it, then you won't have those adhesions.
So what do you do with umbilical hernia? Where do you put the mesh there?
The same. The same. I'm not for putting ventral X because I think you have to expose the intestine to mesh. But this is for a very small part and sometimes you have to do it. But normally I will do all I can in order to close the peritoneum, the lower fascia, and then put the mesh.
Okay. Last comment to Rob.
Really, we have neglected probably one aspect that was mentioned before by Dr. Tollens and maybe by Dr. Corinne. And since we have no time to discuss it, it will become a rhetorical question. Do you remember the 2% mortality that we have with laparoscopic repair? So the question is for all of us lap wizards, does it happen only to less capable surgeons?
It happens to everyone.
Okay. Thank you very much for this interesting discussion.